Today we'll discuss about approach to suspected acute myocardial infarction. Acute myocardial infarction. The classic and most common feature of acute coronary syndrome or acute myocardial infarction is chest pain. Chest pain. Patient with acute myocardial infarction usually come with a complaint of severe chest pain and severe chest pain. The chest pain is typically central, retrosternal, or substernal. Patient comes with a clenched fist over the chest to describe ischemic chest pain. This sign is called Levine sign. This sign is called Levine sign. Levine sign. Levine sign means it is a sign of ischemic chest pain. Sign of ischemic chest pain in which the patient presents with a clenched fist. Presents with this clenched fist over the chest to describe his pain, and the pain is very severe. It's heavy and constricting type of pain. Heavy and constricting type of pain. Patient often describe this pain as a elephant sitting on my chest wall. It is so severe that patient describes as an elephant sitting on my chest wall. An elephant sitting on my chest wall. The pain usually radiates to left arm, shoulder, or jaw. Not only left, sometimes it also radiates to right side of the body, right arm also. Right arm also. So, typical chest pain that is retrosternal in location, central, radiating to left arm, shoulder, jaw, and often patient describes it being heavy, constricting, squeezing chest pain, just like an elephant sitting on the chest wall. Just like an elephant sitting on the chest wall. And there are some categories of the patients who do not experience this chest pain. Who are they? Those patients who have diabetic neuropathy, elderly female, they may not have chest pain. So such a myocardial infarction is called silent myocardial infarction. Silent means chest pain is absent. Chest pain is absent. For example, diabetic patient. Diabetic patients. Elderly female. Elderly female. Why diabetic patients do not experience typical chest pain? Because of diabetic neuropathy. Because of Diabetic patients do not experience this typical squeezing, crossing central chest pain because of diabetic neuropathy. Because of neuropathy. Because of neuropathy. Because of neuropathy. The other possible symptoms of anginal chest pain, other possible symptoms like we also call anginal equivalents are dyspnea, sweating, nausea and vomiting, anxiety, weakness, dizziness, and syncope. The sweating, also called diaphoresis. The patient is diaphoretic. Diaphoresis means excessive sweating. So, chest pain associated with nausea and vomiting, excessive sweating, you should be suspicious of acute coronary syndrome or acute myocardial infarction. So, first of all, we will suspect acute myocardial infarction based on the typical chest pain. So, the next step is to do a 12 lead ECG. 12 lead ECG. It is an essential part of the diagnostic workup. They will ask within how much time we should have done an ECG. It should be done within 10 minutes. Within 10 minutes of arrival of the patient to the emergency department. It should be done within 10 minutes. 10 minutes. A completely normal ECG does not exclude the possibility of myocardial infarction, especially non-ST elevation acute coronary syndrome. So sometimes the ECG will be normal. So we have to do serial ECG. After 15 to 20 minutes, we have to keep on repeating the ECG if we have a strong suspicion of acute myocardial infarction. So, in ECG, which we should have done within 10 minutes after the patient arrives in the casualty emergency department, we'll look for first we'll look for whether there is ECG changes or not, like whether there is ST elevation is or ST segment depression. So this ECG has ST segment elevation. ST segment elevation. This ECG has ST segment elevation. Here you can see this ST segment elevation. This ECG has ST segment depression, and this ECG has T wave inversion. ST depression. T wave inversion. So we can see ST, either we look for whether there is ST segment elevation or not, whether there is ST depression or not, or whether there is T wave inversion. Sometimes nothing can be found. Sometimes the ECG will be absolutely normal. That's why we have to keep on repeating the ECG. We have to do serial ECG. So the next step after ECG is to do cardiac enzymes. Troponin. Look for troponin level. Troponin. Look for troponin level. Most sensitive and specific marker for myocardial injury is troponin. We'll look for troponin level. In this case also we'll look for troponin level. Look for troponin level. Look for troponin level. This troponin can be either normal or elevated. Normal, elevated. Here also same thing. Can be normal or elevated. Normal or elevated. When there is ST segment elevation with normal troponin, ST segment, see this left side, ST segment elevation with normal troponin level, this is called Prinzmetal angina. Prinzmetal. Prinzmetal angina or variant angina or vasospastic angina. Vasospastic angina. The next condition, when there is ST segment elevation and troponin level also elevation, this condition when both ST segment elevated as well as this enzyme is also elevated, this is called ST elevation MI. STEMI. ST elevation MI. ST elevation MI. ST segment is elevated as well as there is enzyme elevation, so ST elevation MI. Now let's see the right side. When there is ST depression or T wave inversion with a normal troponin level, this we call as an unstable angina. Unstable angina. I will write as UA, unstable angina. And when there is ST segment depression or T wave inversion with elevated troponin level, this we call as non-ST elevation MI. Non-ST elevation MI and STEMI. So here we have four conditions. Condition number 1, ST segment elevation but enzyme normal, Prince metal angina. Condition number 2, ST segment elevation with elevated troponin or elevated enzymes, STEMI, ST elevation MI. No ST segment elevation, either ST depression or T wave inversion with normal enzymes, unstable enzyme. ST segment depression or T wave inversion with elevated enzymes, non-ST elevation MI. So we have four conditions, non-ST elevation MI. Along with this, we have four conditions. So how we remember is, angina means only ischemia, no cell death. So the enzymes will be normal. In Prince metal angina, when the word angina is there, in angina, either Prince metal angina or unstable angina, the troponin level will be normal. When the question, there is a infarction, myocardial infarction, whether it is ST segment elevation MI or non-ST segment elevation MI myocardial infarction, the troponin will be high. Troponin will be high. Troponin will be high. Out of these four conditions, acute coronary syndrome includes three things. ACS includes three things. It will include unstable angina and ST segment elevation MI STEMI, non-ST segment elevation MI non-STEMI, acute coronary syndrome. In future, this unstable angina will be removed from acute coronary syndrome. So in future, acute coronary syndrome will have two components, that is ST elevation MI, ST elevation MI and non-ST elevation. Now let's see non-transmural and transmural MI. First of all, we'll read about non-transmural. This is a blood vessel, coronary blood vessel. There is blockade. So there is coronary blood vessel obstruction, coronary artery obstruction. This coronary artery is obstructed. This is a partial obstruction. Partial obstruction. Partial obstruction. But though it's a partial obstruction, it is significant to cause the ischemia, to decrease the blood flow. So they will ask how much diameter has to be obstructed to become a significant obstruction. More than 75%. Some book writes 70 to 80% blockage. I'll take as a more than 75% obstruction is called significant obstruction. Significant obstruction. Significant obstruction. Because of this, there will be reduced blood flow. Reduced blood flow. There is some blood flow is there, not complete obstruction. It's a partial obstruction. So some blood flow is there, reduced blood flow. In heart, blood flows from this direction. Blood flows from epicardium to myocardium to endocardium. So when there is obstruction here, the this area which is farthest from the artery is affected first. This area is affected first. This is subendocardium. This is subendocardial. Subendocardial. Subendocardium. Because this is the least perfused area. Least perfused area. Being the least perfused area, it is the most vulnerable area. Least perfused area vulnerable to ischemic injury. Vulnerable to ischemic injury. Vulnerable to ischemic injury. So only subendocardium is affected here. Only subendocardium is affected, not the entire myocardial wall. Only the subendocardium is affected. So this is a non-transmural injury. Non-transmural. This is non-transmural MI. Non-transmural MI. In ECG, the non-transmural MI will be depicted as either ST segment depression or T-wave inversion. ST depression or T-wave inversion. T-wave inversion. ST segment depression or T-wave inversion, which we call is non-ST elevation MI. Non-ST elevation MI. So the thing which you have to remember is non-transmural MI leads to non-ST elevation in ECG. If you don't know anything, just remember like that. N for non, N for anastemi. NS non-transmural MI leads to non-ST elevation in ECG. Non-transmural, non-ST elevation. N for N. Now let's see about the transmural MI. Transmural means entire layer of the myocardium is involved. Entire layer of the heart wall is involved. Means first of all, this endocardium is involved. Entire myocardial layer is involved and epicardial is involved. How this happens? See, there is a blood vessel. This blood vessel is now, this time there is a complete almost 100% block. So near total obstruction. Near total obstruction. Near total obstruction. which leads to no blood flow at all. No blood flow at all. So, which later will results into transmural MI. Transmural myocardial infarction. Transmural means all layer, entire wall is involved. Entire wall is involved. This entire wall is involved. This entire wall is involved. So this is a transmural MI. This transmural MI in ECG is depicted as ST segment elevation. So we'll see this ST segment elevation. ST segment elevation. So this is ST segment elevation, MIST, STEMI. STEMI. So the two things here important: partial occlusion but significant occlusion, non-transmural MI, non-ST segment elevation, non or non. Complete occlusion, no blood supply at all, entire layer is involved. So whenever there is a transmural myocardial infarction, the ECG will show ST segment elevation. So transmural ST segment elevation, subendocardial or non-transmural ST segment depression or T-wave inversion, that is non-ST elevation MI. Non-ST elevation MI. Now, to diagnose acute coronary syndrome, we have definite diagnostic criteria. We will look for two things. First of all, we will look for the evidences of acute myocardial injury. Acute myocardial injury. Whenever there is an injury to the myocardium because of the coagulative necrosis, the cell death occurs, and those cells who have died, they will release the enzymes, and the most sensitive cardiac enzyme is troponin. Troponin. In troponin also, the most sensitive cardiac enzyme is troponin I. Troponin I is more sensitive than troponin T. Troponin I is more sensitive than troponin T. This will remember as I is important. I for important, most important. I is important. I is important. Troponin I. So this cardiac troponin value above the 99th percentile, upper reference limit URL will take is at a significant value. Plus, there should be clinical evidences of ischemia, myocardial ischemia, clinical evidences. There are 5 clinical evidences. One is symptoms of MI like chest pain, new ischemic ECG changes, appearance of pathological Q wave in ECG, so development of pathological Q wave, then echo findings suggestive of new loss of viable myocardium or regional wall motion abnormality, and angiography showing coronary thrombus. So these five clinical evidences of myocardial infarction. So to call it is a acute myocardial infarction or acute coronary syndrome, we should have one mandatory criteria of elevated troponin, plus out of these five clinical evidences, we should have at least one evidence. So 1 by 5 means troponin T, elevated troponin T along with any one of these findings. These findings just we can remember like that. Number 1 is symptoms, number 2 and number 3 ECG, two ECG findings. These two ECG findings, two ECG findings, and echo findings and angiography findings. So symptoms, ECG, echo, angiography. Again remember symptoms of myocardial ischemia, symptoms, ECG, in ECG two things, ischemic changes, new ischemic ECG changes, and appearance of pathological Q wave, and echo showing regional wall motion abnormality, and angiography showing thrombus. So out of these five, any one criteria is required to call as a acute myocardial infarction. The treatment of acute coronary syndrome, the treatment of unstable angina and non-ST elevation MI is similar, but it is different from ST elevation MI. So for unstable angina or anastomie, the drugs can be remembered as Mona baby, Mona baby, Mona baby. Morphine, oxygen, nitrates, aspirin, blood thinner. Blood thinner means anticoagulation. 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 The usual anticoagulation we use is low molecular weight heparin, or plain heparin also can be used. One of the example of low molecular weight heparin is enoxaparin. Enoxaparin. And we have to give atorvastatin, the usual dose 80 mg atorvastatin, AC inhibitor, beta blockers in selected group of patients. Sometimes there are contraindications which we'll discuss in detail later on. P2Y12 inhibitors like clopidogrel we have to give. Clopidogrel. Clopidogrel. Clopidogrel is an antiplatelet agent. Antiplatelet agent. Antiplatelet. So in EMI we give aspirin. This aspirin is also an antiplatelet. Antiplatelet agent. And clopidogrel is also an antiplatelet agent. So there are two antiplatelet agents. So that this is DAPT, dual antiplatelet therapy. For in MI we have to give dual antiplatelet therapy. One is aspirin, one is clopidogrel, clopidogrel, clopidogrel. So whenever you suspect a patient with myocardial infarction or acute coronary syndromes, don't wait for the diagnosis. Then and there, you give at least 3 drugs. For ACS, at least you give ACS. Aspirin, first starting dose of 300 mg. 300 mg. Then you give clopidogrel. Clopidogrel 300 mg. You give statin. In statin we give atorvastatin. 80 mg. This is ACS package. ACS package for a patient who presents with the features suspicious of acute myocardial infarction. One thing you remember that in Mona baby, the drugs are not given in this sequence Mona baby. It's just a mnemonics to remember. We give nitrates, sublingual nitrates. If the pain is not subsided by sublingual nitrates, then we'll go for morphine. Oxygen will not give oxygen to everybody. If SpO2 is less than 94%, only then we'll connect oxygen. So remember this Mona baby for non-ST elevation MI. For ST elevation MI, the drug list is almost same, but except 1 or 2 differences. The mnemonics is not Mona baby, it is Sonam baby. Sonam baby. This you will remember like this. S for Sonam, S for ST elevation MI. So here we have streptokinase. Streptokinase is the oldest drug used for thrombolysis. Here we'll do thrombolysis. Thrombolysis with streptokinase. Streptokinase is not an ideal thrombolytic agent. There are many other. So we'll do thrombolysis. In ST elevation, we'll do thrombolysis. By doing thrombolysis will dissolve the thrombus and will restore the blood supply. That means we'll do reperfusion. This is a kind of reperfusion therapy. Reperfusion therapy. The best way of reperfusion therapy is primary percutaneous intervention, PCI, that we'll discuss in some other class. Now you just remember for ST elevation MI, we do thrombolysis, we do reperfusion therapy. Then other things are almost same: oxygen, nitrogen, aspirin, morphine, blood thinner. Blood thinner means the anticoagulation. Heparin, low molecular weight heparin, anticoagulation. Atorvastatin, AC inhibitors, beta blocker. P2Y12 inhibitor is another antiplatelet agent. Example is clopidogrel. The detail of the management we'll study in the next class.